rainy clips. Let me get on the other side.
The applier doesn't go in the
Oh, you got it? Yeah. Wait a minute, what happened to the other ones? No, we have some different ones. We used to have 4. Like it could bust. So, for this particular patient, it did. So the brain just started filling up with blood. So it's a pool of blood inside, right inside the wound there. And the surgeon had to go in blind and clip it because now the patient's gonna bleed to death. He was able to do it. You can imagine. Every time I did those cases, I was just like this. Because you never know if you're going to hit it and it bleeds and then the patient can expire. But the clips, the aneurysm clips, that's a whole nother trade with all these different clip sizes. And clip appliers come in different angles, 5 degree, 10 degree, 50 degree angle. The clips themselves are all these different sizes. I think they're in your book, right? You have a picture in your book? No, the aneurysm clips? Yes. And then when you first start, you want to make sure that you have a standard clip applier with a standard or an emergency clip, which is always gold tipped. That's how you know they're emergency clips. Like if they get in there and they have the clipper right away, you have to have something for them to give them right away. The thing about the clips, once you have, it's sort of like the rainy clips, when you apply them, they stay open. That's how you hand it to them, they're open. If you do that, then you never want to use it. They don't use it, you never want to put that one back in the tray because now it's been open, so it's been compromised. And that's going to stay inside, right? That's going to clip that way. What else can I show you? Any other questions about the instruments? Speak now. Did you guys see the bone wax?
Is that prepared or
I'm sorry?
how do you pass that?
This?
Yeah, bone.
There's 2 different ways you can pass it.
This closed?
So if you're putting it into the burr holes, you want to wad it up. You just have it like this. And you just put it right in the hole. Sometimes if they're doing like back surgery or like lumbar surgery, they might use a little bit on the tip of a number 4 pencil, like this. But that's like for back surgery. And then you just kind of want to stop some bleeding on the bone. So this is for bone, this is like a hemostatic agent for like bone. I've seen people play with this in surgery because they're bored and make things out of it. Like an artist or like a dog or something. I'm not good at that stuff. So that's how you use it. And sometimes they like you to hold it in your hand because it softens it. So they might say just have somebody hold some in your hand so you can put it on the side. It does get soft by the heat. Okay. Any other questions? Well, here's the Surgicel. Thing about the Surgicel, you can't get it wet. So what you want to do is you want to use dry instruments. See how that looks? So you would use an instrument that's not wet, that's not being used, and you will lay this on a towel, and you will lay it out, and then some like this, so you have like a stamp size, So that's the surgery cell. They also use this in ear surgery as well. Again, this is a hemostatic device.
And again, when you cut those into strips, are you cutting into the strips that the surgeon prefers, or
Different sizes,
different sizes?
so then they're available. So same thing goes with the gel foam and the drummer. But that's going to go into a container because that's going to be wet. That's the opposite of this. Oh, this goes up here. This takes a lot of work. So what you do is when you're studying for a procedure like this, see all the stuff you have to have? And again, all we have is one tray. This is not sufficient. You're going to have the micro, you're going to have the suction, you're going to have the drill, you're going to have other microscopic instruments. You're going to have the short needles, you're going to have the medium, and you're going to have the long. Just like you have the suctions. So you're going to have medium, and you're going to have straight, and you're going to have curved, and you're going to have finer, and then some that are not so fine. Then you're going to have all of these dissectors that are microscopic. That's a lot of setting up. Think about it, right? And then you're going to have to cut this, and then you have to cut the gel foam, right? Then you're going to have all these cotton, it's going to be like 100 cotton noids. They're all going to be different sizes. You're going to have the half by half, the half by ones, the 3 by 3s are the big ones. Or you might have the micro. It depends on, they have the Fukushima, they go from different, they go by numbers. These all have to be counted. The other thing about this is that you're going to have to find a way to lay it out so that they can use it. Some trays come with like a little plate, so you can put all these on there. Because you're going to have to be able to make it available for the surgeon. So let's say we don't have MSS basic. So let's say you don't have a tray. So what you do is you'll cut this, just cut it, and then you will lay them out like this, like two different sizes, and then you're going to take this and you're going to clamp it on the drape. So if they need something, they can grab it. Does that make sense?
I mean, yes. Let's see if we...
So you're going to lay them out like something like, you know, and like in order, so they can see them. Something like that. And also for you, you need to grab them. Sometimes they might have you place something for them. And you're always going to use a bayonet, or they're going to use their bipolar, because again, it's a bipolar. So this is how you lay it down like that. When you're doing the neurosurgery, they're going to be using a microscope, so they're going to be under the scope once they get to the dura, or right before, right at that point, after they make they take the bone flap. They're going to go under the scope, so everything is going to be, they're going to be looking down in the scope, and you're going to be handing them the instruments under the scope. So that's a little bit more difficult than just regular surgery. And you have to make sure that when you're putting their instruments in their hand, you're really putting it properly in their hand, so they can grab it. And when you're passing up a bayonet, this part goes up. And it goes right where the fingers are pinch like this. So then let's say they want, more than likely they're going to want the bayonet and the bipolar, or the bayonet and the scissor. So what they'll do is they'll grab the tissue, they'll get the bipolar, and they'll cauterize the area. And the next thing they're going to want is the scissor, because they're going to cut. They're going to be going through just a real micro dissection. It takes about maybe 4, 5, 6 hours, depending on the tumor, depending on what they're doing. Take a long time. The setup I said was about 45 minutes setup, but you're putting the patient to sleep. They're drinking the patient, putting all these lines in, and they're positioning the patient, and just all this stuff that needs to happen. So you're setting up while they're doing that. But you wanna set up the main stuff and then start cutting those surges out, then start cutting the drum, and then doing all that. Cause it takes that long to set up. It's a long setup. But this is major surgery. Like, this is not an accident. This is a big deal. Okay, any other questions about instruments or setup?
With the Mayo stand, what would that setup look like?
Okay, so the Mayo stand, we do have a picture somewhere along. Let's see. On the Mayo stand, you're gonna have your basic instruments. You're gonna have a curved Mayo scissors. You're gonna have a straight curved Mayo. You're gonna have your mitts and bombs. You're gonna have some, probably like some tissue versus fatigue, acids with teeth. Because now remember, we're still talking about, the first thing we're gonna do is cut the scalp. So you're gonna need something to hold on to the scalp. You're gonna have your rainy pliers or your gun. You're also gonna have your periosteal elevators. Because once they get past the flap, the skin flap, then they're gonna go to bone. So you're gonna need all the bone stuff. That's one setup. And you're gonna use you're gonna need some, a couple of clamps. Because remember, sometimes I said they might tag down, they might just use a regular hemostat to tag things down, you know. But for the most part, that's it. When you're doing your setup, you're gonna have one for your larger and going in instruments, and you're gonna have another Mayo stand for your micro surgical instruments. So what's gonna be on that Mayo stand is gonna be your scissors and your fine dissecting forceps. You're probably gonna have like some little bulb of irrigation. You know, like the ones that you have for the eye, the BSS, but they're non-disposable because sometimes they need to irrigate, but they don't want the big irrigation bulb. You're gonna have these as well, but you're also gonna have the fine ones. So that's gonna be all the micro stuff. Then you're gonna have another Mayo stand, and that's where the drill's gonna be. So you're gonna have about 3 Mayo stands. Now they do use like a Finland table, which is a big, long table. Let's go back to that. 'Cause I'm so short I can't reach over, you know? So I'd rather have 2 Mayo stands than to use that Finland table. Okay, but I guess some hospitals do use that Finland table. And it's the same table they use for the open heart. It's this big, it's like a Mayo stand, like a mama bear Mayo stand. Real big and wide. Not that mamas are all big and wide. You know what I mean, right? Okay. So you might also have some retractors up when you're first going in. So it just depends on how the surgeon operates. So any questions about the Mayo stand setup?
How do you, like, what's the best way to position yourself with all these Mayo stands and all these?
You're gonna be over the patient.
Oh, okay.
The head's gonna be here. Alright. Now, you're gonna have, the drill's gonna go here, because the surgeon's gonna need to use it, right? It'll be right here. Your other Mayo stand is gonna go right over here, on this side. Probably, the first one in this side.
You said, there's 3 parts, the perforator and the craniotomy.
So we'll go to that right now. 'Cause we only have that. So this is the Unspock Black Max. This is a little bit more modern, and that one's a little older. This one is, this is a Godman. So they have different brands. So, but this is the, start with this one. They are, they run off the nitrogen, so off either a tank or the wall. This is the actual perforator itself. So then you would have to hook it up to the hose and make sure you get it in there and snatch it in place, because otherwise it'll pop out and it can miss it in place, right? So make sure it's secure. Can you guys get closer? You guys can actually see what I'm talking about?
That little notch.
Mm-hmm. Okay, so that's the perforator. And on the perforator, you're gonna use a 14 millimeter, see it says it on there? 14 millimeter perforator. So this is the drill bit you're gonna use. And this, how this goes in, you push it back, like a Jacob attachment. Put this in, make sure let it up and then make sure it's on there. And then, most of these have safety devices on them. This one says reverse and this one says on. And you can tell it's really old. And then they just do it like this. Right? Okay. So that's the perforator. Now this, remember I was telling you that sometimes they have it where you have to switch the ends out? This one, you don't have to. So this is the craniotomy. Now they have this is the guard here, that's what you have. These come off and they have different sizes. So we don't really have one that fits, but this is the actual craniotomy. This looks like it's a pediatric craniotomy because it's short. This is the one that's going to make the long incision that's going to remove the cranium. This will go in here. But it doesn't because it doesn't fit in. It's not the right one. And then the guard. Just that doesn't fit, doesn't go in. So anyway. You get the idea. So let's say this is the craniotomy that you would hook up. Right? Trying to make it fit, but it doesn't. So that'll already be ready to go. As soon as you're done with this, then you can switch it to the drill bit. That would go here. Again, it doesn't fit. So those are the three. And you automatically do it.
So if that drill setup is on the other side of the surgeon, do we want them to come and change it out?
You can. Or they could grab it. But as long as you're still gonna need to do some movement because you're gonna need to switch it out. Now on this one here is a little different. This is a little fancier. And see how this one has all of these attachments. These are all different drill bit attachments. This is what this is. Okay? So obviously they could use this for more than just the cranium, right? They're not gonna need this long drill bit. Right, that's pretty long. So again, these are just different attachments. These are all for drill bits. Or they could be for burrs. Remember the one video that showed you they're doing burrs? So this is like for a burr. And it has like on here to tighten it, put it in, loosen it, tighten it in. So I'll press this around, kind of like move it around like this. And it tells you secure release. It's kind of user friendly, right? So I'll pass this up. This is like for a drill bit. They could be diamond, and they could be bigger. Just like how the suctions are bigger, you can start bigger burrs, like if you have a bigger bone to cut through, and then you can go smaller, 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 like a 6, 5, whatever, and then you can go diamond, which is less, it's more for finer work when they start getting closer to tissue. Because you're going through bone and you're trying to get to tissue, you got to go big, like a big burr. I wish I had one to show you. And then smaller, and then diamond. Okay, it's like you know how when you have the nail file, how you have the real coarse and then you have the finer. So like the drill bit's kind of like that. Okay, so I'll pass that one around for that. And then so let's see. On this one here, And that towel was in place because you don't want to lose your cord. You just put it on top of that. You don't want to lose your cord, right? So that's just a way of, a fancy way of securing your cord. On this one here, so it's the same principle on this one. This is also a 14, and it's the same kind of release, quick release. Comes right here, and that one goes on here. Let's see, where's the cord for this one? Oh, somewhere. Okay, just a little bit. Bear with me here for a second. When you get into the or you start messing with things because you sort of have to learn as you go on some things. So on this one here, the handpiece itself turns into the craniotomy, but then the perforator gets attached to that. See how I was able to easily do that without it taking me forever? You just have to keep trying things. This is what they call troubleshooting. Make sure that you're so on this one you have the perforator. And once you do the perforator and you make the holes, then you release it again. And then you switch it to the the craniotomy. You put the drill in it. Because otherwise you can't get it in, right? And then you put it in. You have to make sure it locks. That's in there. And that's what the craniotomy looks like. See that? That's how it should look. It's supposed to be straight. But it's not. It's supposed to go right into the little clue right there. Well, I think this is bad. But you get a chance to look at that. Now, if they're doing the drill bit, now you need another piece. Does that make sense? Mm-hmm. So like, I don't have a drill bit to put in there. But it could be something like, any of these will do. Short one, you don't need a long one. Because you're going right there on the cranium, which is surfacey. You're not going deep. You don't necessarily need a big long one. But you need a shorter one. So you would just switch it out. And then the drill goes right in there. So there's three, the perforator, the craniotomy, and the drill bit. And all you're doing, watch me as I do it, as soon as the perforator's in, you switch to the craniotomy. As soon as this is done, you switch to the drill bit. They're not gonna say, okay, can you switch now? They're expecting to be ready for you, ready to go with these. Any questions about this?
So would this be the more effective piece to use during the test versus this one over here? Or seeing as how we have to have that transition to go from perforator to
We're gonna use this. We're gonna use this one.
Okay.
That's so ancient. Yeah, we're gonna use this.
Okay.
Okay. I'm gonna put these back. Where's the other ones? Where's the other? It's already on there. It's already on there. Okay. So your job is, when you come in, we're gonna go like we always do, run through the case, and then when it's time for the perforator, when you come in, you could already set this one up, right? Mm-hmm. If you could do that as part of your setup. As soon as the burrs are in, then you push it out to the craniotomy, right? You're gonna need to do that, and then you're gonna put it on the drill. And you don't get to do it. You don't get to practice very much at all, really. You don't get to put your hand on this one because it's already past 2. But I'm just saying, if you wanted to stay and do it, that's fine. We have some people coming down here at 2 o'clock, which is fine. But if you want to hang out and practice, I'll hang out with you guys for a little while. So you can at least get some practice or just put your hands on. At least do the drill part. I do this and switch it out so you can